models before this one have all been on, to my knowledge, have all been on imaging data. Now, of course, you don't have imaging data outside the hospital unless you have something like a mobile stroke unit, which is sort of an extension of the hospital. So that's not really applicable before the patient is technically recognized and brought to the hospital. That has some limitations, and that doesn't really aid us where we're trying to start as early as possible to aid the patients as fast as possible, get them more of the advanced treatment. Our model has limitations as well. So one limitation is that this is a retrospective study. We haven't tried this on live data. This isn't as big a deal as it might be, since the model is, we call it an artificial intelligence. It doesn't really think, it's advanced statistics. So it's not going to make a decision, and it doesn't know that these calls aren't live. We've asked it to just look at the entire call and make a prediction. And it can do this fast enough that it doesn't matter whether it's live or not. However, all we can see here is how it performs if the dispatcher just took everything it said for granted. Like they believe every single case where the stroke warning comes up, then they get a 63% recognition. But in reality, that rarely happens. So you have to think about implementation of this. That's also why before I talked about how important it is to have both good recognition and good positive predictive value, because everyone has tried some sort of supportive tool that just suggests something all the time, and you turn it off because it doesn't really work for you, it doesn't really aid you, you can't see the benefit. So if that happens with a tool like this, well, then it won't get used, and it can be as right as you want it to be, but that won't help you. So you need to think about implementation to actually make it clear, make it helpful, and make the ones that are supposed to benefit from it feel like this is a supportive tool, this is something that helps, sort of like the spell checker. Everyone loves spell checker because, it's hard to spell. So you need to feel like this and not feel like it's something you're being forced to use, it just pops up, it's just annoying. So that's I think that's a limitation as well. And certainly it can only learn things that it was in the training data set. So, for example, we would hope that it learns the trickier cases as well, but it will of course be better at learning the common cases, just like people are, because there are more of those, so it learns more from those. And the strokes that are not recognized on the phone and never turn up in hospital, the ones that have a mild stroke and that should stay at home, see a GP, he doesn't or she doesn't figure out it's a stroke either. We will never know, and we can't really train it on those. But for the calls that we know are strokes, it is really a broadly applicable supportive tool that I can see aiding the ones that are making the triage if implemented correctly. This is a tool meant to aid the ones doing the triaging. This tool wouldn't be able to take over the job. You couldn't just hire the robot and then have it triage all the calls. It needs the conversation, the back and forth between the telephone operator and the caller in order to work at all. So this is just the next logical step, really, in order to aid them in the difficult tasks. So that's usually what I end on.